So Nilji, are we ready?
We can start, sir.
Okay. So good evening, friends, and welcome to this 37th episode of All India Postgraduate Teaching Program, an initiative from ARC AIOS. This PG program is slightly different from the other PG programs because in this teaching program, we have modalities like case presentation, journal clubs, OSCEs, and rare didactics on topics which are not comprehensively available on textbook. So this is the 37th episode of this series. Today we will be having two short cases on oculoplasty. The first short case would be presented by Dr. Kalisipudi Shruti, who is a third year junior resident from Government Regional Eye Hospital of Vizag, and Dr. Shine, who is a third year DNB resident from Little Flower Hospital, Angamali, Kerala. I'm extremely thankful to both the mentors, Dr. T. Jyotirmay, who is a professor at Government Regional Eye Hospital, Andhra Medical College, Vishakhapatnam, and Dr. Annie Sridhar, who is Unit Chief of Oculoplasty and Neuro-Ophthalmology Services at Little Flower Hospital, Angamali. My special thanks goes to Dr. Lakshmi Mahesh, who is a consultant orbit and oculoplastic surgeon at Sakra World Hospital, Bangalore. Dr. Maya Hadda, who is an associate professor at Department of Ophthalmology, SMS Medical College, Jaipur. And a dear friend of mine, Dr. Milind Naik, who is an ophthalmic plastic surgery and facial aesthetic surgeon at LVPI, Hyderabad. I'm really thankful to all three of you for finding time and consenting to be an examiner for this particular episode. Without much ado, can I request Dr. Shruti to share her screen and let's begin the case. And once more, the externals can ask the exam right from the word they present their history so that the students learn. So 10 to 12 minutes is what their presentation time cumulative is, and 20 minutes is going to be the discussion. You can intersperse between this. This 20 minutes can be in during the course as well.
Good evening, sir.
Yeah.
Good evening, respected professors. I am Shruti.
The screen is not yet shared, Shruti.
Yes, sir. I'm sure.
Yeah.
Third year.
Now it's okay.
Yes, sir.
Go ahead.
Sir, first of all, I'd like to thank AOC ARC for this opportunity, sir. I'd like to thank Dr. Prashant Bavankle, sir, and my mentor, Dr. Jyotirmay Madam, for guiding through this. Sir, shall I start the case?
Please, go ahead.
A 25-year-old male patient hailing from Vishakhapatnam, who is a computer operator at a junior college, came with a chief complaint of drooping of upper eyelid right eye since birth. History of present illness. The drooping of upper eyelid right eye is present since birth. There is no diurnal variation. It is not improving with rest. No history of any diplopia. No history of any difficulty in swallowing or change in voice. No history of any eyelid swellings. No history of any elevation of this droopy eyelid while eating, chewing, or any jaw movements. No history of diminution of vision. No history of excessive sweating on one side of face. No history of any limb weakness or no history of any dry eye. His birth history is normal. A full term, normal vaginal delivery, 2.6 kgs, underwent an institutional delivery. No history of any previous ocular surgeries or any ocular trauma. No history of any eye inflammation or eye allergies. It's not a known case of diabetes or hypertension. No history of any bronchial asthma or thyroid. No history of any other chronic illnesses or any significant drug history. There is no family history of ptosis, drooping of eyelids. Personal history, he takes mixed diet, appetite is normal, normal bowel and bladder habits. On general examination, patient is moderately built and nourished and is conscious and coherent. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. On systemic examination, cardiovascular system, S1, S2 are heard, no murmurs. Respiratory system, normal vesicular breath sounds are heard. On CNS examination, no focal neurological deficits, and on GIT examination, parabdomen soft and non-tender. Head posture, there is chin lift present, and right brow lift is present. On extraocular movements examination, full and free in all cardinal directions. You can see here, there is no restriction in any case. On ocular examination, right eye, visual acuity is 6/6. Eyebrow, there is a right brow lift is present. Eyelids, eyelid drooping is seen. Faint lid crease is seen. Lacrimal apparatus is normal. Eyeball size and position are normal. Conjunctiva is quiet. Cornea is clear, transparent, and sensations are intact. Anterior chamber, normal depth and contents. Iris color and pattern are normal. Pupillary reaction is normal. Pupil size and reactions are normal. Lens is clear. Coming to left eye, visual acuity is 6/6. Eyebrow normal. Eyelids are normal with normal lid crease. Lacrimal apparatus is normal. Eyeball size, position are normal. Conjunctiva quiet. Cornea clear, transparent with intact sensations. Anterior chamber, normal depth and contents. Iris color and pattern are normal. Pupil normal size and reacting to light. Lens is clear. IOP is measured with applanation, right eye 13 millimeters of mercury and left eye 14 millimeters of mercury. Coming to fundus examination, right eye, media are clear, optic disc size, shape, color are normal, margins are distinct, cup disc ratio is 0.4:1, vessels are normal, A is to B ratio is 2:3, macula is normal, FR is plus. Left eye, media are clear, optic disc size, shape, color are normal, margins distinct, cup disc ratio is 0.4:1, vessels are normal, A is to B ratio is 2:3, macula is normal, FR plus. Coming to ptosis examination per se, right eye, palpebral fissure height is 6 mm, MRD1 marginal reflex distance is 0 mm, MRD2 is 6 mm, MRD3 is 2 mm, LPS function measured with Burke's method is 4 mm. Marginal crease distance, crease is very faintly seen, so couldn't be measured. Palpebral fissure height is measured in primary position, up gaze and down gaze. Sorry, there is a... In up gaze, it is 7 mm, up primary position 6 mm, and down gaze in 6 mm. Left. Coming to left eye, palpebral fissure height is 10 mm, MRD1 is 4 mm, MRD2 is 6 mm, MRD3 is 7 mm. LPS function measured with Burke's method is 15 mm. Marginal crease distance is 8 mm. In primary position, left eye, palpebral fissure height is 10 mm, and in up gaze, it is 11 mm. Down gaze, it is 5 mm. It is ptosis of 4 mm, so it is severe ptosis. Vertical lid height, right eye is 18 mm. Tarsal platform show and brow fat span are 5 mm each. Left eye, vertical lid height is 20 mm, and tarsal platform show and brow fat span are 5 mm each. Visual fields are done on confrontation. There is no restriction, and it is done on lifting the eyelid. Schimmer's test is normal in both eyes. Greater than 15 mm wetting is seen. Bell's phenomenon is good. Marcus Gunn jaw winking phenomenon is absent. Lag of thalamus is not there. Ice pack test and fatigue test are negative. Phenylephrine test is not done here as it is severe ptosis. On downward gaze, ptotic lid is higher in position than normal. On cover test, there is no improvement of ptosis. Summary, a 25-year-old male with complaint of drooping of upper eyelid right eye since childhood. On examination, there is a head posture, there is chin lift and brow lift present on right side. Forehead furrowing is seen and there is severe ptosis. Faint lid crease with poor LPS function is seen and higher position of ptotic lid and downward gaze. So, by this, my provisional diagnosis is unilateral congenital severe ptosis with poor LPS action right eye and left eye is normal. Thanks.
I think the case is open for request the examiners, Dr. Lakshmi, Dr. Maya, Dr. Melin to.
Dr. Shruti, do you have any diagram of clinical photographs of these examinations we were expecting? Like LPS, leg of thalamus and the palpebral fissure height. How do you measure the Bell's phenomena and how to check the MRD1?
No, sir. No, ma'am. I don't have anything.
Okay, so can you go back to the first photograph of the patient?
Yes.
Okay. So you said there was a chin-up position. So
Yes.
when do you expect a chin-up position in a patient of ptosis?
If torticollis is covering the pupil, for vision, he'll lift the chin and tries to see.
So that scenario which is seen in unilateral cases or bilateral?
In bilateral ptosis.
Right. And what does this brow lift signify?
Overaction of frontalis muscle because the LPS is weak. Frontalis is trying to elevate the upper eyelid.
So the palpebral fissure height you said in the up gaze was 7 mm and in the primary gaze it was 6 mm and in the down gaze again it was 6 mm. So what do you expect in a case of congenital ptosis? What will happen to the palpebral fissure height when the patient will look down?
Pal- LPS fails to relax on down gaze now, as it is a dystrophy of LPS here. Mostly there will be widening of palpebral fissure.
Yes. So
Dr. Maya, can you be louder, please?
I am saying that this is not a case of ptosis; it's a case of blepharospasm. So how will you counter that? The patient is squeezing his eyes and it's a blepharospasm.
Lower lid is in normal position.
Yeah, okay. One another most important point. So in a ptotic eye, what will the patient try to do? Lift up the lid by
Elevate the upper
raising
eye.
the eyebrow. Yeah,
Frontal
eyebrows. Yeah.
brow
See,
lift.
the eyebrow level is very important, I think, in when you decide which surgery to do and all that. No. So always look at the eyebrow level also. This both are at a normal level, yeah, equal level. Okay.
Right eyebrow lift is there, ma'am. Here,
It's there. It's in the photo. It's not seen that much. Yeah. So, what are the protective mechanisms that you should look for? Is the patient when you lift up the lid, what happens? Always there is a lag of thalamus, isn't it? The lag of thalamus is there during sleep and also when looking down. So, what are the protective mechanisms which are red flags, which you should tell the patient about? So, what are the examination points?
so post-op complications.
Yeah, where you will anticipate more complications.
Poor Bell's phenomenon or
Yeah, poor Bell's phenomenon.
um, lid lag burn.
Lid lag may be there in congenital ptosis even
Corneal
before surgery. Yeah,
corneal sensations if they're absent.
yeah. Usually it's not no unless there is a facial nerve palsy, fifth and sixth and all that.
Here, Schimmer's test.
Yeah, shimmer But in children, you need not look for poor bells. Poor bells and will not may not should not deter you from doing surgery in children. Why? What is the difference between adults and children regarding Shermer? Children have a good tear film, isn't it? So in children, even if they have a poor bells, you can do surgery. Okay, you need not even uh, indicate to the parents about the lag of thalamus or anything. Okay.
Dr. Lakshmi, ma'am?
Okay, let's have it like tuck, 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 tuck. We'll go to the first slide. So, Dr. Ani raised a very important question, Shruti. You have presented the case extremely well in detail. Maybe as Maya put in, you could have had some more pictures for benefit of, the other students who are watching.
Yes.
Now, the thing is history. So, how if the examiner asks you why is it not blepharospasm, you should first of all say, Madam, the patient has had this since birth. So this is against blepharospasm, correct? So now we go back to diurnal variation. Where do you get diurnal variation?
Myasthenia gravis.
Good. not improving with, okay. So what are the main categories of ptosis which you have? 4 main categories or 4 types of ptosis.
Congenital, acquired.
Types, okay, the causes, 4 causes.
In acquired, urogenic,
Ah.
myogenic, traumatic, and mechanical.
Excellent. Okay, now you go to the SO history of swelling, all that comes off in this. Next, you go to next slide. So excessive sweating on one side of face. Why do you want to ask that history?
Honors.
Very good. Excellent. What do you get in honors?
There will be anhidrosis on one side. So patient perceives as excessive sweating on one side.
So that usually due to what cause?
Sympathetic.
Okay. Why do you, okay, sympathetic overactivity? Okay, fine. Limb weakness. Where do you get your limb weakness? Why do you ask that history?
Any third nerve palsies with brain syndromes.
Generally, no, but maybe some bells where there is, or some kind of a seventh nerve, or some
Seventh.
kind of a aberrant regeneration or things like that after injury, especially. So there, the history of trauma again is very important. Next, go to the next slide. Okay, all this is fine. This much history I'm not sure because I'm not been examiner of late. For short case, you need to ask so much of history. You just check it out. Please see the norms for that. I'm not very sure, but excellent. You've done all this. Next, history of any inflammation. Why?
Any eyelid inflammations or cicatricial conditions may also.
No, don't go to cicatricial now, please. Inflammation. Why that word inflammation and that allergy? What happens one ptosis which comes in puberty? I'm giving you the
Blepharochalasis.
clue.
Blepharochalasis.
What happens in blepharochalasis?
Due to repeated inflammations and allergies, there will be destruction of tissues. So tarsal plate will be destroyed. And
You can't say destroyed. It's nothing will happen. There will be inflammation. There will be edema. That if you want, you can confirm on a scan. There will be usually preseptal edema. So it usually correlates with the pubertal age, especially in girls with the menstrual history. They may get those attacks. So what happens progressively when you get those attacks of blepharochalasis? What happens when you examine this patient? What happens to the skin?
Skin will have cigarette paper appearance.
No, cicatricially. Yes. It will have a wrinkled appearance. Exactly. So you will ask, and generally in these cases, it will be as if they're having excess of skin, but they are still very young. So you have to wait for the inflammation to completely subside, before you really undertake. Mostly it's done for cosmetic purposes. If they get over it and they don't have too much of a issue and lack skin, then you can leave it. Next, quickly. Okay, all this is fine. Next, we go to fundus examination. Okay, next. Why do you do a good fundus examination? Of course, you have to do a complete examination. Ocular movements, very important. Superior rectus function, which is the main part for the bells, is very important. Here, you should know what is reverse bell. As Dr. Ani said, infant corneas and the child corneas they tolerate dryness better. They are more resilient. You can operate them even if the bells is a little weak. But you should know what is reverse bell. It goes in the opposite direction.
Downward direction. Downward direction. Reverse
Correct.
bell.
Yeah. Now, why do you look at the retina? Very important. Of course, you should, for every oculoplastic case, we should see the retina. You should know what's happening behind, because though your patient knows that you're not doing mainly for vision, they will, if they complain something, we should not cut a sorry figure. Oh, that was problem in the retina. But particularly one particular retinal condition where you can have,
in Kearns syndrome, pigmentary
excellent,
retinopathy.
very good. You are very well prepared. Well, in addition to retinal pigmentary retinopathy, what else you have?
Salt and
Salt and pepper.
Conduction. Heart
change. Very good. Excellent. Okay. Then go ahead. Okay, MRD1, MRD2 for exam point of view, 100% important. But palpebral fissure, Berkey's test, it's called Berkey's method. Okay, Berkey's test, marginal crease. Okay, fine. Go ahead. Next. Okay, up gaze, down gaze. Severe here because the pupil is involved. Okay.
No.
Next. Okay, next. Okay, fatigue test, ice pack test, all that you have nicely explained. Thinking harness, you should know a little bit more about the etiology because there the management will vary. That I would want you to look into because in exams these are the things which they like to concentrate more rather than the more simple mundane ones which we use generally as practitioners for the sake of doing the surgery. Okay, still it holds good that if the levator function is less than 4 millimeters, what would you like to do? Now coming to management, which Dr. Ani was asking you.
Frontalis sling surgery or supramaximal LPS resection.
Nowadays, there is also one more newer means it's becoming
Small.
popular. Milind has a good case series. I think Maya also has started. Frontalis,
Frontalis sling.
exactly. Using the frontalis muscle as a sling, correct? Yeah. So I think that is, you should be aware of that also.
Yes.
So that in the for the exam point of view. Okay. Next. Okay, next. So what have you advised for this patient?
Patient will come next week, ma'am, for frontalis sling surgery.
Here, I think since he's already 20 plus now,
Yes.
we could consider one of these because sling, all said and done, you're using an external material. You will be, hanging the whole thing there. It's not cosmetically that great a surgery when compared to those two fail, you can always keep sling as your next option. So since you but for the exam purposes, you have to say sling. But since you already told about maximum LPS dissection and you talked about frontalis sling, I mean, using the frontalis muscle as a sling, then I think you should keep this as a second option, is my opinion. Let's hear from Milind and Maya and your mentor what they have to say. Thank you very much.
Dr. Milind.
Yeah, hi Shruti, well presented. I just wanted to make 2 points. With your measurements, this is a general guideline for all students. Make sure that your MRD 1 and 2 always totals up to the palpable fissure height because that has to add up.
Yes.
And particularly when you are checking for levator function, when the examiner asks you to do it in front of them, make sure that the head is resting on something
Yes.
hard and it's not mobile. And you also compress the frontalis when you are examining.
Bilateral.
The only other comment I had was about your diagnosis slide, provisional diagnosis. There, I would like to add one more word in your diagnosis. Can you think of that? Congenital, severe, something else. Congenital ptosis is again divided in 2 types, simple and
Simple. Yes. Simple.
So the moment you say simple, I know that this patient doesn't have Marcus Gann or any other issues associated. Great work.
Is the time up?
Yeah, no, there's still time for it. But madam, can we have the comments, final comments from the mentor, Dr. Jyotirmay ma'am? Very well.
Shall I-
Sir, good evening, all of you, sir.
Good evening.
Good evening, ma'am.
Yes, sir. Actually, I'm a general ophthalmologist. I'm not an oculoplastic surgeon, sir.
No, good.
Yes,
But I
sir.
think
But your word has presented very well.
Yes.
Yes.
Theoretical, we are able to give, but I'm a general ophthalmologist, sir, madam. Can we plan for sling, sir? Sling, madam, frontal sling?
Yes, I think.
I
so.
think Milind will be the best. But I would not. What is Milind's view? What is Maya's view?
I think frontalis sling will be the best option.
So you have three options here. One is supramaximal or maximal levator resection, then a standard tarsofrontal sling, and the newer methods like frontalis flap. So when you are a student, you're answering when you say that, okay, the levator function is 4 mm, the safe answer is to say that this patient is suitable for a frontalis
Yes.
sling, which can either be a silicone or a suture. So
What is the ideal material if the examiner asks you for frontalis suspension surgery?
Ideal method is autologous facial. I think.
And
Nowadays, we are using silicone sling.
What are the other materials that you can use? You can.
That's a very important question, favorite question.
Yeah.
Supramide suture, Gore-Tex, and Mercilin mesh also.
Any non-absorbable. Any
Non.
non-absorbable. Proline, 10-proline, Ethibond. So then will come the question, what is Ethibond? Refer. Refer and tell us next time.
yeah, Shruti, just one more tip. Whenever you take patient photos, they should be as bright as your selfie, which you are going to upload on social media. Okay. So always think of that. If the photo is not good enough as your selfie, then it's not good enough in a presentation. Just keep that in mind.
I like the way you put it across, Dr. Menon.
Yeah.
Great, great. So, Shruti, you did a fantastic job, I think, on TOSIS. I hope the students have learned a lot from how the quiz of a short TOSIS goes, right from the word you say presenting complaint to your provisional diagnosis. How you approach that is what we learned from Shruti, and how various examiners will catch you at various points, what you should speak, what you should not speak. Also, you need to remember, even while you are presenting a negative history, what would happen is if you have such a long negative history, you will give the examiner more chance to deviate away from your case, and your process will be left at one corner. So you should present whatever is minimally left for means in the negative history and relevant to that particular point. This is what we should all learn from it, but very well presented. So I think, what should we say, all the examiners distinction, because she has already presented, was already assured by me, and she has of course done well. So how much should we go above 75 to score out of 100?
I'll
Not
put it around 90.
90.
Yeah, me too.
Prashant,
Wow.
not just
How much time do you get to take a short case?
In a examiner, madam, I think madam and you people are better people too. I think 15, 20
I don't
minutes.
know. Shine. I don't know if Shine knows.
process is a short case,
Yeah.
Maybe.
I
20
think
minutes.
15 minutes at least.
15 minutes. That time you have to write down, you have to come to a diagnosis, write it down, no? And then present. Without writing, they can't. Now all that in 15
Many
minutes.
times for DNB, I have given TOSIS as long case only.
Okay.
I don't know. So, and these days I don't know. That's why I asked you all.
Usually the cataract, glaucomas and all, which go for a major case, and other subspecialties, they go for a
Dr. Prashant, we lost you.
yeah.
For,
No, I thought
Usually
it was.
the cataracts, glaucomas and all routine cases which go as a long case. The short cases are usually various subspecialty cases. That's what I was told, and this is what I have gathered it from various places. So this is an effort for that. So very well presented, Dr. Shruti, and also Dr. Jyotirmay ma'am. We congratulate you for having your words so well prepared, and
Thank you, sir.
thank you for that.
Thank you for the opportunity, sir.
No. Thank you, ma'am. And now let's move on to the next case presentation by Dr. Shine, and he's from Angamali, and his mentor is going to be that Dr. Annie. So, Dr. Shine, without much ado, can you share your screen? And best luck.
Is it visible, sir?
Yes, let's in a presentation mode. Sunil? Sunil ji, can you guide me?
Yes.
Slideshow.
Slideshow.
Is
Dr.
it okay, sir?
in a slideshow mode.
Slideshow.
Is it
Shine.
visible, sir?
It's not downloaded, Doctor.
It's downloaded. It's in my laptop itself, sir.
Put it in
Just
slideshow.
just click on the top from current slide. It's actually showing in a yeah, perfect.
Yeah.
Come on. Great. Best of luck.
Good evening, everyone. First of all, I would like to thank iOS for this opportunity and my mentor, Dr. Annie Madam, for guiding me through this. And we are going to discuss about two lid tumor cases. Coming to the first one, it's about a 64-year-old male who is a manual laborer coming from Ernakulam, and he presented with a right upper lid swelling for 4 years. He noticed the upper lid swelling since 4 years, and it was gradually increasing size, and he noticed the growth increase in size since 8 months. There is history of incision and curettage done twice from elsewhere, and the tissue was not given for biopsy, and also a shave biopsy from the swelling done from elsewhere on 13/10/2023 and showed poorly differentiated sebaceous gland carcinoma. There is no history of carcinoma in the family, no similar symptoms in the family. On general examination, it was found to be within normal limits, and the systemic examination was found to be within normal limits. Ocular examination is best corrected visual acuity is 6/6 in both eyes with powered glasses, and near vision is N6 in both eyes with powered glasses. There was no facial asymmetry, no abnormal head posture. The extraocular movements are full and free in all direction of gazes. On coming to the examination proper, on inspection, there is a fleshy looking multilobulated swelling 3 into 4 mm in size on right upper lid involving the lid margin, extending from the upper lid margin and beyond the mid-tarsal area with irregular borders and loss of surrounding lashes. On eversion, it was a multilobulated growth with the surrounding dilated vessels and congestion with the yellowish deposit on the mass. On palpation, it was a non-tender, firm swelling with a thickening of tarsal plate up to 12 mm vertically and 4 mm horizontally. There is no regional lymph node palpate at the preauricular and submandibular areas. Slit lamp examination showed right eye mechanical ptosis. All other findings as mentioned before, and the both eyes corneas are clear and normal. All other anti-segment examination was found to be within normal limits. The fundus evaluation was normal. To summarize the case, a 64-year-old male swelling on right upper lid for 4 years with history of multiple incision and curettage with a swelling size of 12 into 8 involving the lid margin extending beyond the full width of the tarsal plate with loss of lashes without involvement of regional lymph nodes with the previous biopsy showing sebaceous gland carcinoma. My provisional diagnosis, right upper lid sebaceous gland carcinoma. The management plan we did for this patient is white tumor excision with 4 mm clear margin with lid reconstruction with a tensile flap. The histopathology showed infiltrative neoplasm composed of varying sized globules, and the individual cells are pleomorphic, polygonal, clearing with nucleus scalloping and prominent nucleoli. It was suggestive of sebaceous gland carcinoma, and the base and margins are free of the tumor. This is the 2 weeks post-op of the image of the patient. Should I go to? Yes, sir.
Shine, did you mention about the lymph nodes?
Yes, sir.
Okay, I missed it.
In the palpation, I have mentioned about the.
Perfect. Perfect. No problem.
Should I go to second case or?
Yeah, let's finish both.
Okay. The second case is about 59-year-old male who is an auto driver. He presented with swelling on left lower lid for 5 years. He noticed the swelling since 5 years. It was blackish colored swelling, which was gradually increasing size, and there is one episode of bleeding from the lesion. There is no history of trauma, no history of trauma to face or around eyes. He was a case of psoriasis on treatment with methotrexate. There was no lesions on the face. He is also a CAD patient on ecosprin and cloplet. There is no family history of similar symptoms in the family or family history of carcinoma. General examination was found to be within normal limits. All other systems were within normal limits, and cranial nerve examination was found to be within normal limits. Ocular examination showed best corrected visual acuity of 6 by 6 in both eyes with power glasses, near vision of N6 in both eyes. There was no facial asymmetry, no abnormal head posture. Extraocular movements were full and free in all direction of gaze. On examination proper, on inspection, it's a 1.5 into 1 centimeter in size pigmented ulcerative lesion on left eye lower lid with irregular borders and rolled out edges with central ulceration and surrounding erythema, and the lid margins and puncta were not involved. On palpation, it was non-tender, firm, pigmented swelling that bleeds on touch and moves along with the underlying skin, and is freely mobile over the underlying bone. On eversion, conjunctiva was not involved. There was no regional lymph node palpable. Slit lamp examination was found and showed the above mentioned signs, and the both eye cornea was clear. All other anti-segment examination was found to be within normal limits. Lens was nuclear sclerosis, grade 1 in both eyes. Fundus examination was normal. To summarize this case, a 59-year-old male coming with swelling of left lower lid swelling for 5 years, 1.5 into 1 centimeter pigmented ulcerative lesion on the left eye lower lid with irregular borders and rolled out edges with central ulceration without involvement of regional lymph node. My provisional diagnosis: left lower lid basal cell carcinoma. Management plan we did for this patient is tumor excision and lid reconstruction with 4 mm clear margins with the base free from tumor. Histopathology report showed well circumscribed neoplasm, large basal lobules with the peripheral nuclear palisading, cleft formation between tumor lobules and stroma. It was suggestive of basal cell carcinoma, nodulocystic variant. The base and margins of excised lesion were tumor free. This is the 2-week post-op image of this patient.
Are you through? Dr. Shine?
Yes, sir. It's over, sir.
Okay. Can I request the examiners to take over?
May
Dr.
I?
Manu, you are muted, I believe.
May I?
Yeah, please go ahead.
So, Dr. Shine very well presented both cases.
Thank you,
One,
madam.
I would like to tell you that whenever you are giving a diagnosis, it will be very impressive if you include AJCC classification. Okay, so like your first piece, you mentioned it's 12 by 8 mm in size.
Yes,
So
madam.
AJCC, it's involving the full of the tarsal thickness.
Yes,
There are,
yes, madam.
so which category or how do you label it according to AJCC? You have to go through that. Okay, it will be T2B and 0. So that will be very impressive if you include that in your diet. Likewise, in
Okay,
second,
madam.
just said it, lower lid basal cell carcinoma. So I think mentioning the involvement is also important, that not involving the lid margin and what is the extent of involvement. Like in the palpation also, you didn't mention about the adherence to the underlying, structures. That is also important in BCC cases. But it's mobile,
Yes, madam.
yeah. And tell the palpation findings, don't mention swelling. swelling is like when the patient gives history to you. So you have to, use your scientific terms at that time.
Okay, madam. Okay.
Otherwise, very well presented.
Thank you.
Yes, ma'am. Meenakshi ma'am. Lakshmi ma'am. You are muted, ma'am. Madam, you are muted.
Sorry. First case, how many times was incision and drainage done for the suspected chalazion before the
Two.
gentleman presented with that lesion?
2 times he has done from outside, madam.
So both the times the biopsy was done, or second time the biopsy was done?
Both times the tissue were not sent for biopsy, madam. Third time he done a shave biopsy from some other place. Madam.
So 3 surgeries were already done before he came.
Yes, madam. Yes, madam.
If you notice very carefully the clinical photo, if you want, you can go back to that for the benefit of the students. You can see that there is a diffuse swelling of the upper lid, pushing up the brow a little upwards. So when you say there was no preauricular node, especially when there are already 3 times surgery done, I think here there will be some evidence will be needed. You may have to go for an ultrasound or a scan of the neck to make sure it's not there, the lymph nodes, because these days we are seeing so with this immunohistochemistry, we are seeing so many variants, and even in a male patient with sebaceous gland carcinoma, if you have to think of even examining the breast of the male.
Okay.
So these are cystic lesions which are known to have correlation. We are having now a lot of case reports coming in where we have to do n number of tests. So we think, probably it's a sebaceous gland carcinoma, the story is over. I'll do a nice excision, wide excision with reconstruction. Right now, the story is not over, especially those aggressive ones where 3 IND or has been done and they present the 4th time. We really don't know whether we are able to do justice, because you can have skip lesions. So you
Okay,
can
ma'am.
have skip lesions. So that's why those map biopsies and all have been discussed. So these MOS, that is of course for BCC. So skip lesions can be there. So I think this part is very important. And as a student, I think we have to tell you to emphasize on frozen section study. See, it's after all the basic. If I want to have, if I am undergoing a study, I want frozen section to be done on me. So I think frozen section plays a very important role, where especially in a teaching hospital, where you're giving a good margin, and that is a recurrent case. So how is this can be prevented? What should have been done in the first time when he had a chalazion, which was not painful and was a lump? What is the age of the patient? Can I ask? Once again, the age of the patient, 40 plus, right?
50
46,
plus
right?
56.
50. So what, any chalazion, which doesn't look into that, which doesn't fit into the perfect description of a chalazion, with some distortion, loss of lashes, so you evert the tarsal plate, loss of the normal tarsal plate anatomy. First still, when you're doing an IND, please go for a biopsy. So it can avoid, because we have had instances where we have lost the patient also, despite multimodal therapy. For sebaceous gland, which are so recurrent and which are so aggressive, we have to start multimodal in certain cases where we can't really clear the tumor. We have to start them on chemo, then give them radiation, then continue them on chemo. For just one chalazion which started, which would have been easily, and you don't want, we are losing patients also. We don't want to lose any patient because of a chalazion. That should be the bottom line for eyelid tumors. Eyelid tumors, I will not lose any patient.
Yeah,
Aggressive
especially I
orbital
think
tumors,
when you do,
metastasis.
when you do an INC, if you don't get any granulation, then you have to take a wall biopsy, isn't it? No?
See, that
If you don't
very
get
well,
any-
that's a very important question, ma'am. You please put your clamp or scope, clamp, and you make the initial cut, right? You make the initial nick. Take a, if you're not getting, you're getting only solid tissue, then gently with the Westcott scissors, you excise it, but make sure you've not got pus, you've got only thickened tissue, excise it, but take the two small lips of the wound, about 1.5 millimeters of the wound, like an oval shape, the lip of the wound, you please send it for biopsy as well.
Right.
That will usually be positive.
Okay.
And elderly patient loss, as madam said, any other warning sign, you have to take a biopsy.
Exactly, exactly. And as a student, I think you should emphasize about the frozen section, and you should
Yeah.
also know a little bit about the histopathological features. Why is it called sebaceous gland? And in Indian subcontinent, why in the south we see more of sebaceous gland carcinoma? India as such itself, we see more of sebaceous than I think it's now taking over even squamous cell. So that you have to say. And I think all these points you should keep in mind, because the lymph nodes, I don't think just palpation will be enough. You need imaging.
Yes,
So
ma'am.
that point you can just emphasize.
Okay, ma'am.
Thank you. But you've done a good job.
Thank you, ma'am.
As far as your second case is concerned, I wanted to know how exactly was it excised and reconstructed. Can I just know that from your Dr. Ani and you?
Yeah, yeah. I just it was not adherent to the orb. It was not orbicularis was not involved actually. So I just excised the whole thing with a 3 mm margin, and even a little bit of the lid margin, the outer part of the lid margin was taken. And by undermining the skin, I covered most of the wound, but a little bit was for primary healing by primary intention. And thankfully, everything was tumor free post-op.
Okay. There's a small wedge there in the lower lid.
Yeah,
There's a
lid
little,
where
with that I think you'll have
yeah,
to
I
keep
had
a
to,
close watch. Because
yeah,
all said and done, I completely agree with you because of your seniority and experience. I will not refute what you said that it was not, but
frozen section.
we
Yeah,
know
we
that
don't
these
have to,
basal cells are rodent ulcers. They do go
yeah,
deep. And
yeah.
on this table they spring, they look like a small 1 centimeter lesion, but sometimes you can get a defect of up to 2.5 centimeters. So I'm glad to know that the orbicularis was not involved in this
Not
case.
involved
Generally,
at
it
all.
is involved.
And should we have taken a biopsy first? That is what I think students should say, no? Take a wedge biopsy first and then go in for the
No, ma'am,
isn't that
this
what?
has got classical science. I don't think
No,
with
no
a
need.
person like you who knows what to do, I don't think we should
No,
take
for
a
the
post.
students, I think they should say wedge
Okay.
biopsy first and then go in for a definitive surgery. That's
I
what we
think
should
I'll
say.
get
And also
Milind's and
frozen
Maya's
section.
opinion in this. I don't generally do that for basal cell. What would Maya and Milind do?
For such well-defined small lesions, I think we can go for primary excision with frozen section. And if you are planning some radical surgery or a large flap reconstruction or exentration, then definitely an incisional biopsy first.
No, but for the students, they should say, first incision biopsy. This is not a claim. This is for the PGs. Shouldn't they say that we should first do a small incision biopsy and then go on for a
If it-
definitive surgery?
if it's having a definitive clinical picture that nodulo-ulcerative picture, telangiectasias and all, then and it's quite excisable, so we can go ahead with primary excision.
Yeah, I think Maya is right, madam, because the classical rolled out edges, the central ulceration, all very typical features when they are there. I think it's
Yeah.
right.
And
And
another interesting point is he was on treatment for psoriasis, and so and Shine found that is something there was a relationship
Relationship.
between psoriasis and
can you please highlight on that?
yeah, Shine.
The the tumor and psoriasis not directly related, but the treatment of psoriasis like PUVA therapy and methotrexate usage is somewhat correlated. Incidence of BCC is slightly higher in those patients, as I read from a meta-analysis study. So there is a relationship between the treatment of psoriasis and the BCC incidence of BCC.
Oh, I was not
So we
aware of
don't,
that. Thank
yeah,
you.
we don't usually ask for the history, the patient. I don't know, somehow we got that history.
But what was the history of psoriasis and what was the history of this pigmented lesion? Noticing the pigment duration, I mean.
Duration of psoriasis, how long did he have?
Diagnosed about 10 years, madam.
And the
Using
pigmented lesion, did you
methotrexate.
notice? Pigmented lesion?
5 years, almost 5 years, madam.
So I think we will have to consider the link.
Yes, ma'am.
Dr. Milind?
Yeah, I think both cases were great. And as a student, in your case presentation, maybe for the first case, you can also add that patient had mechanical ptosis just to complete your diagnosis for theoretical purposes. And just one question, whether you would do any systemic evaluation for your case number 1. And
Yes,
if
sir.
it is, what would you do?
Since sebaceous gland carcinoma is more prone for metastasis and lymph node involvement, we should systemically evaluate for any metastasis in lungs, liver, all other blood investigation and chest X-ray imaging modalities we should do.
Right. So you could either do these or you can do a PET scan.
PET scan.
Whole body PET scan is costlier, but that definitely pick up findings. Is there any specific largest diameter of the tumor beyond which you would worry more about systemic metastasis?
More than 10 mm diameter is risk factor for more metastasis.
Exactly. Thank you.
Thanks.
And between the liver and the lung, sebaceous gland is more prone to go to
Lungs.
lungs, correct. Whereas basal cell hardly goes anywhere. It just keeps burrowing and goes deeper there, right?
Yes.
So,
Yeah.
the time is up.
Almost, I think.
Almost. Okay.
Dr. Annie, ma'am, you can now sum up for the case for the sake of
Yeah.
all.
So, what are the red flags that you should take a biopsy in a calassium? What are the you have to take a biopsy in a calassium? What are the points?
Recurrent episode, same site.
Said earlier, no, just say repeat it once again, Shine.
Recurrent
Site.
Same site involvement, recurrent times without any pus or drainaging.
Yeah.
And
Then
there is any surrounding signs like loss of lashes, rounding of the posterior lid margins, and
extension.
extending beyond the tarsal plate, and in any intrinsic vascularization or feeder vessels.
Okay. Elderly patient, hard. These are all the things you have to take a wall biopsy. Okay. Then what else is there? Is a sentinel node biopsy being done anywhere in India? I don't know. Is it relevant? Sentinel node biopsy. What is a sentinel node biopsy?
We have any suspicious of lymph node involvement. The first drainaging lymph node biopsy from the first drainaging lymph nodes.
You inject a dye and then.
It always have to go to the preauricular before it goes to submandibular, or can it skip the preauricular?
What is the drainage of the lids? What is the lymphatic drainage of the lids? Upper lid, lower lid. How is it divided?
Upper lid 2/3 and lower lid 2/3.
2/3 lateral or medial?
The upper lateral 2/3 drain to pre-auricular lymph nodes, and lower 1/3 to submandibular nodes.
No, lower 1/3, lateral 1/3 also to the preauricular. Lower 2/3 medially goes to the submandibular, and upper 1/3.
Okay.
Just like this, I think. Okay.
I think this is a very, very important question. Kindly note.
Are there any other questions that we should anticipate?
I think the basics of it is a little time. If they are answering all questions well, they may ask the basics of lid reconstruction.
Yeah.
So in any lid reconstruction, what is the basics? See, what are all the flaps and all? It depends on exam. It goes up to the super specialization, that's all fine. What is the basic three layers which are very important in any eyelid reconstruction?
Oh.
Can you tell us?
Basic 3 sizes. ಅಲ್ಲ?
Three layers which are important in any lid reconstruction. We are talking only about eyelid reconstruction.
The anterior layers, including the skin and subcutaneous tissue up to the tarsal plate, and the posterior layer of.
First of all, how will you split the lid? The lid has 4 layers.
Yes, madam.
Which is that layer? Which is that line which splits the anterior lamella and posterior lamella?
The gray line, which
Exactly. So anterior lamella, what do you have?
Skin and subcutaneous tissue.
What is subcutaneous tissue? That is the beauty of the eyelid.
Orbicularis muscle.
Orbicularis muscle is there is no subcutaneous tissue as such. Some loose areolar tissues, but it's mainly orbicularis. And what is a posterior lamella?
Tarsal plate and conjunctiva.
Conjunctiva. So when you talk about lid reconstruction, you won't say these layers. You will say first is cover, which is skin, support. What will you give support for tarsal plate? And then lining. Lining for conjunctiva, mucosa, whatever. So all lid reconstructions, these are the 3 bases. What is the cover? What is the support? Middle layer. What is the lining? Inner layer. Okay. You have to think like that, and then it becomes very easy. It is like somewhat like mathematics. This layer, this goes, that layer, that goes, what I will do. Lid sharing, non-sharing, flap. What is the difference between flap? What is the difference between flap, and what is the difference between graft? These are some basic questions you will have to know. Thank you.
Okay, madam.
Okay, one last question, Shaheen.
Yes, madam.
Your case presented as recurrent chalazion. So sebaceous gland carcinoma is a great masquerade. So what can be other presentation of a sebaceous gland carcinoma, not nodular, which can be atypical presentation?
Chronic blepharoconjunctivitis may present as thickening of the lid and
Okay.
So how do you detect it?
The patient will have history of recurrent redness and discharge from the eyes.
What biopsy will you take?
Shave biopsy.
Shave biopsy. What biopsy? Chronic, it is on the surface. So what biopsy will you take? Just we had mentioned earlier one. Lakshmi ma'am had mentioned.
Wedge biopsy.
On the surface.
Wedge biopsy.
On the surface. Map biopsy. On the surface. Map biopsy. So how many points do you take map biopsy? You forgot your posting in oculoplasty. 17, I think. No? Milind? 16 or 17 points.
Yeah.
Refer and tell. Okay.
Frank with you, I don't do it, Annie. But when I see a patient with severe discharge and infection, and that I like to give steroid antibiotics for at least 2 weeks, see how everything settles down, then do the biopsy. With so much of inflammation, sometimes there's so much of bleeding, it puts you off. And when there's infection and there's discharge, you don't want to do surgery. So you can give it a little bit of time and allow that to subside.
You can,
but I think you have to, for examination's sake, we have to talk about map biopsy, and we have to also talk about this Mohs micrographic, though most of us don't do it, but I think that's just to be just exam point of view, we'll have to know what it is.
I think we had a good session this case, Dr. Shaheen. You really did fare really well. So Dr. Milind, Dr. Lakshmi, and Maya. I think we will ask Maya. She'll be the junior most, as she quoted. How much would you like to rate her?
I think 90 will be good.
Okay, so both of them have done wonderful job. Both of them score 90%. So I think all of us should clap for them. In fact, standing or a sitting ovation for all of you. Seriously.
And both are eligible for a Plasti Fellowship also.
Oh,
Yeah.
Excellent. That's very nice of you, Milind.
so look, Dr. Shine and Shruti, what you could do. You should thank me for that. Okay.
Thank you, sir.
You're getting a direct offer from LVPA for a oculoplasty fellowship and none other than Dr.
Not
Milind.
even campus interview, online interview.
No,
Online.
offer for an interview, not for fellowship.
No, no, I stand corrected, I know, but you have impressed the dawn of
No,
oculoplasty.
wonderful. Really done well. Both of you.
So I think we should congratulate both of you, Dr. Shruti, Dr. Shine, for having presented and worked hard to create that case for everyone. And of course, both the mentors, Dr. Jyotirmay ma'am and Dr. Annie, for okay.
Thank you very much, sir.
Thank you very much. And of course, all the mentors who are very proud, and I can see them gleaming now with confidence and joy for the students.
Thank you.
And all the examiners, Dr. Milind, Dr. Maya, and Dr. Lakshmi ma'am, for being with us and sparing their valuable evening with us for these postgraduates. I'm really thankful and indebted to one and all of you. Thank you once more. So,
Thank you. Thank you very much, Dr. Prashant. Thank you so much.
thank you. So it's
Thank you all.
time for us to say bye-bye. We will be meeting on the following Thursday again at 8 to 9 p.m. Probably that time we are having a journal club. So get ready for that.